So in renal disease, muscle relaxant that can be given is, so topic about muscle relaxants. Brief topic of muscle relaxants. Muscle relaxants are classified into centrally acting muscle relaxants, peripherally acting muscle relaxants. Peripherally acting muscle relaxants are classified into those that act directly on the muscle and those that act at the neuromuscular junction, right? So can anybody tell me the examples of centrally acting muscle relaxants? Come on, I want you to participate. Dantrolene does not cross the blood-brain barrier. It's not centrally acting. When I mean centrally acting, it crosses the blood-brain barrier and inhibits the central nervous system. Okay? And thereby causes muscle relaxation. Centrally acting muscle relaxants. Centrally acting muscle relaxants. Come on, tell me the examples. Tizanidine. 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 What is tizanidine? Alpha-2 agonist. Useful for spasticity due to multiple sclerosis or spasticity due to neurological problems. Okay? So tizanidine is one example of centrally acting muscle relaxant. Chlorzoxazone is another example. Carisoprodolol. Baclofen. What is the mechanism of baclofen? GABA. GABA action. Okay? These are the 4 examples of centrally acting muscle relaxants. These are centrally acting muscle relaxants, so they cross the blood-brain barrier and cause muscle relaxation. Because they cross the blood-brain barrier, they are lipid soluble, right? So therefore, these all can be taken orally. Why are they lipid soluble? So they can be absorbed by the gastrointestinal tract. Remember, for example, brand name Zerodol MR. When you have spasticity, when you have muscle spasms and pain, when you have inflammation and pain, we all write Zerodol MR or Hyphenac MR, etc. They have these, one of the drugs. They can be taken orally and they cause muscle spasticity. Okay, they are not powerful. So they do not cause diaphragmatic relaxation. They do not impair your respiratory system. Okay, but they cause muscle relaxation. These are centrally acting muscle relaxants. In contrast to centrally acting muscle relaxants, you have peripherally acting muscle relaxants. These can be classified into those that act directly on the muscle or those that act at the neuromuscular junction. Can you tell me an example of a muscle relaxant that acts directly on the muscle? Dantrolene. Dantrolene, drug of choice for malignant hypothermia. Okay? Dantrolene. Dantrolene is the one which acts directly on the muscle. Dantrolene. The neuromuscular blocking agents are the ones which are useful in anesthesia. These can be classified into depolarizing relaxants and non-depolarizing muscle relaxants. What is the example of depolarizing relaxants? Choline, succinylcholine. How it is metabolized? Pseudocholinesterase or butyrylcholinesterase, etc. Non-depolarizing muscle relaxants are classified into, anybody? Steroidal muscle relaxants or benzyl isoquinoline compounds. Okay? Centrally acting relaxants, peripherally acting relaxants. Those that act directly on the muscle, those that act at the NMJ, neuromuscular junction. Depolarizing, non-depolarizing. Non-depolarizing classified into steroidal and benzyl isoquinoline. Examples of steroidal muscle relaxants, please. Come on. Rocuronium, vecuronium, pancuronium, pipecuronium, all stuff. Uroniums. Uronium. If you have, oh, it's a steroidal muscle relaxant. Okay? Uronium. These are steroidal muscle relaxants. Examples of benzyl isoquinoline. Atracurium, cisatracurium, okay, etc. Mevacurium, etc. Alright? Now, the more the duration of the relaxant, the more it is excreted by the kidney. The more the duration of the relaxant, the more it depends on the renal function to be excreted. For example, you take pancuronium. Pancuronium is the longest acting muscle relaxant, works for 1 hour. A single dose of muscle relaxant paralyzes you for 1 hour. If you want to suicide, shoot that. Pancuronium, okay? For 1 hour you won't be taking a breath. Alright? So it is completely excreted by the kidney. Completely excreted by the kidney. For example, you take vecuronium for contrast. What is the duration of action of vecuronium? 20 minutes. Vecuronium works for 20 minutes. So, it is 60% metabolized in the biliary tract, another 40% excreted by the kidney. Okay? So, the longer the duration of the relaxant, the more it depends upon the renal function to get excreted. Alright? You understood? What is the other property of pancuronium? One other property of pancuronium? It inhibits the norepinephrine reuptake. Okay? It inhibits the norepinephrine reuptake. It's something like tricyclic antidepressants. It inhibits the reuptake of norepinephrine, thereby increasing the norepinephrine concentration in the synapses. That leads to hypertension and tachycardia. The side effect of pancuronium is tachycardia and hypertension. Tachycardia and hypertension. So regarding pancuronium, the duration of action is 1 hour. The other special property of pancuronium is it inhibits the reuptake of norepinephrine, thereby making you have more heart rate and more blood pressure. Okay, pancuronium. Vecuronium has no effect on the heart rate. Vecuronium has no effect on the heart rate. It depends upon the biliary excretion. Vecuronium depends upon the biliary excretion. It's got no effect on the heart rate. So, muscle relaxant of choice in myocardial infarction. Vecuronium. And sometimes they say, stupid questions. Sometimes they say muscle relaxant of choice in a cardiac patient. You have to assume that cardiac patient is myocardial infarction or coronary artery disease. That's a stupid question, but they keep asking. Okay? So, vecuronium is a choice for myocardial infarction. Why? Because of no effect on the heart rate. Long-term infusion of vecuronium causes what kind of disease? Polyneuropathy. So therefore, long-term infusion of vecuronium is not indicated in the ICU. We don't use vecuronium in the ICU. The first reason is because if you want to use in the ICU, it works only for 20 minutes. So every 20 minutes you need to give the loading dose. And the other problem is long-term infusion can cause polyneuropathy. So therefore, the relaxant of choice in ICU is going to be ROCU, rocuronium. The relaxant of choice in ICU is going to be rocuronium. Okay? What is the other property of rocuronium? Other special feature of rocuronium? The onset of action is 1 minute. Whereas all non-depolarizers, the onset of action is 3 minutes. All non-depolarizers, the onset of action is 3 minutes, except rocuronium. Rocuronium, the onset of action is 1 minute. Succinylcholine, the onset of action is 30 seconds. Okay? I know it's jumbled, but I'm trying to keep it as simple as possible. The onset of action of succinylcholine is 30 seconds. Because the onset of action is 30 seconds, it is a choice in something called as rapid sequence intubation. I need to intubate rapidly, as rapidly as possible, okay? So, drug of choice for rapid sequence intubation is succinylcholine, 30 seconds. Duration is 5 minutes. Any drug that is metabolized by pseudocholinesterase, the duration is 5 minutes. Any drug. What are all the drugs that are metabolized by pseudocholinesterase? So, drugs metabolized by pseudocholinesterase. Scoline, mevacurium, remifentanil. What else? Ester local anesthetics. Very good. What else? Okay, we'll discuss as the class passes by. Alright. So, rocuronium. What is the reversal agent for rocuronium? Specific reversal agent for rocuronium. Sugammadex or Sugammadex, whatever. Sugammadex or Sugammadex. Okay, this is a specific reversal agent for rocuronium. What is this? Su is sugar. Gamma is gamma in structure. Dex is dextrin. Okay, Sugammadex is a specific reversal agent for rocuronium. Okay, So nowadays, the choice of rapid sequence intubation is rocuronium followed by sugammadex. In the olden days, it was succinylcholine, but now rapid sequence intubation is replaced by rocuronium with sugammadex. Why? Rocuronium onset of action is 1 minute. Sugammadex can be given as early as possible. Okay, the moment you intubate, you can give sugammadex. All right, right. So rocuronium plus sugammadex is replacing succinylcholine for rapid sequence intubation. Though the cost in Indian rupees, sugammadex is 80,000 bucks for single injection. Okay, interesting point. All right. So tell me the answer. Muscle relaxant that can be given in renal diseases. Doxycurium. What is doxycurium? Doxycurium is long acting, very potent. Long acting, very potent. It's long acting, so it depends on renal function. You want to give that? No. Pancuronium, it's longer acting. It depends on the renal excretion. You want to give that? Pancuronium? No. Vecuronium, 60% metabolized by the liver. Only 40% depends on the kidney function. So you can happily give vecuronium. Okay. Gallium. What is gallium? Gallium scan for detecting infectious lesions. Okay. Probably the choice should be galamine actually. Galamine. Galamine is also excreted by the kidney. Galamine is also excreted by the kidney. Okay. Gallium is gallium scan for detecting infections. Okay. That's a different one. Right? Any doubts in this? Any doubts? No. Very good. Fastest onset skeletal muscle relaxant is scoline. If scoline is given, scoline 30 seconds. If scoline is not given, rocuronium. Okay. All right. All statements are true about skeletal muscle relaxants except. So mevacurium is hydrolyzed by plasmacholinesterase. Is it right? Yes. It's metabolized by pseudocholinesterase. So onset of mevacurium is 3 minutes. Duration is 5 minutes. Onset is 3 minutes. Duration is 5 minutes. Mevacurium. Okay. Rocuronium is largely excreted unchanged in the urine. That's false. Okay. Pancuronium blocks the uptake of norepinephrine. Yes. Atropine is degraded by Hoffman's elimination. True. Okay. So you know the answer. Okay. Galamine is excreted mainly through. Just now I told you, right? Galamine is excreted through the kidney. Okay. Galamine. The other thing about galamine is it crosses the placenta. Only muscle relaxant that crosses the placenta is galamine. Only muscle relaxant that crosses the placenta is galamine. Galamine crosses placenta. Galamine crosses placenta. Okay. Which muscle is most resistant in neuromuscular blockade? Diaphragm. Diaphragm is the muscle that is most resistant to neuromuscular blockade. Okay. Diaphragm is the one which is most neuromuscular. Therefore, it's blocked the last. The last muscle to be rendered paralytic after muscle relaxant is diaphragm. It can be asked in two ways. The question can be asked in two ways. Okay. Pseudocholinesterase degrades mevacurium. You see the questions? It's the same thing that's getting repeated. Just seeing from the back or front, from the side, but the same concept. Okay. The drug used for D-tuberculosis reversal is reversal agents. Okay. Most of the muscle relaxants or non-destabilizing muscle relaxants are competitive blockers of nicotinic receptors. Okay. Most of the muscle relaxants are competitive blockers of nicotinic receptors. So therefore, if you want to reverse the patient, you need to increase acetylcholine levels. Right? They are competitive blockers. It just depends upon the concentration of the relaxant versus the concentration of ACH, acetylcholine. If acetylcholine levels are high, then the muscle paralysis is reversed. Okay. So how do you increase the concentration of acetylcholine? How do you increase the concentration of acetylcholine at the synapse, at the neuromuscular junction? How do you increase the concentration of acetylcholine? One way is to stimulate the presynaptic terminal, right? If you stimulate the presynaptic terminal, more amount of acetylcholine is released into the synapse, and therefore the patient gets reversed. So what is the drug that does this? What is the drug that stimulates the presynaptic nerve terminal to increase acetylcholine levels? 2-aminopyridine. 2-aminopyridine. It was used as a reversal agent in 1940s. 1940s, it was used as a reversal agent. it would stimulate the presynaptic nerve terminal to increase the concentration of acetylcholine in the synapse. Because non-depolarizing muscle relaxants are competitive inhibitors, when you increase acetylcholine levels in proportion to curare drugs, the paralysis is reversed. Okay? But what is the side effect of 2-aminopyridine? What is the side effect of 2-aminopyridine? Seizures. Seizures. Why seizures? It is stimulating the nerve. It's stimulating the nerve. So therefore it stimulates the neurons in the brain. Has a side effect of seizures. Almost 90% of patients given with 2-aminopyridine has seizures. So therefore we are no more using 2-aminopyridine as a reversal agent. So what is a better way of using reversal agent? To inhibit acetylcholine esterase. This is the enzyme that metabolizes acetylcholine. So if you inhibit acetylcholine esterase, indirectly you are increasing the levels of acetylcholine. Thereby you are reversing the patient. Okay, what are the drugs that are inhibitor of acetylcholine esterase? You have physiostigmine, neostigmine, pyridostigmine, and edrophonium. Which one you want to use? Neostigmine. Why neostigmine? Very good. Physiostigmine crosses the blood-brain barrier. So you don't want to have the side effect of increasing acetylcholine levels in the brain. So therefore we use neostigmine that does not cross the blood-brain barrier. It's a quaternary ammonium compound. Quaternary ammonium compound, whereas physiostigmine is tertiary ammonium compound. It crosses the blood-brain barrier. Okay? Edrophonium is very short acting. It works only for 5 to 10 minutes. Right? Neostigmine acts for 1 hour. Pyridostigmine acts for 6 hours. So pyridostigmine is the reversal agent of choice in renal failure. In renal failure, I want to make sure that the patient is reversed for 6 hours than 1 hour. Just on the safety side. So reversal agent of choice for renal failure is pyridostigmine. Okay? In all other conditions, neostigmine is the reversal agent of choice. Where is physiostigmine useful for? What is the utility of physiostigmine? Physiostigmine, physiostigmine, whatever you call. It's useful for what? There is something called as central anticholinergic syndrome. There is something called central anticholinergic syndrome. Have you guys heard about atropine psychosis? You are all interns, finished internship? You give tons and tons of atropine. What the patient does? Hallucination, right? He's going to shout, he's going to act like a psycho and all that stuff. It's called atropine psychosis, which is otherwise called central anticholinergic syndrome. Okay? It's basically you're blocking the muscarinic receptors in the brain that causes hallucination. So how do you prevent that? You give physiostigmine. When you give physiostigmine, you're increasing the levels of acetylcholine, thereby preventing the action of atropine. Okay? So the treatment of choice for central anticholinergic syndrome is physiostigmine. That's the only utility of physiostigmine right now. Okay? What is a drug that is usually given with neostigmine for reversal? Atropine or glycopyrrolate. Why? Because neostigmine not only increases acetylcholine at nicotine receptors but also at muscarinic receptors. Right? So thereby the patient can have bradycardia, salivation, lacrimation, dumbbells. Remember dumbbells? All these side effects can be present when you give neostigmine. So to prevent muscarinic effects, you always combine atropine or glycopyrrolate along with neostigmine. Okay? Glycopyrrolate is better because the effect on the heart rate or causing blood-brain barrier is limited. So when using as a reversal agent, we use neostigmine plus glycopyrrolate. Does Sagamadex require glycopyrrolate? Sagamadex, a reversal agent for rocuronium, does it require glycopyrrolate? How does Sagamadex act as a reversal agent? You give IV Sagamadex, it just floats in the blood, captures rocuronium, gets excreted from the kidney. It's not by inhibiting acetylcholine esterase. Okay? It just captures the drug, gets excreted. So do you require to give glycopyrrolate? Absolutely no. So glycopyrrolate is not indicated with Sagamadex. That is one other advantage of Sagamadex. What is a reversal agent for ganticurium? Ganticurium is a very new muscle relaxant. Newest muscle relaxant, ganticurium, or shortest acting non-depolarizer muscle relaxant. Shortest acting non-depolarizer muscle relaxant is ganticurium. Shortest non-depolarizer is ganticurium. Shortest non-depolarizer. What is the reversal agent of choice? What is the reversal agent of choice? L-cysteine. L-cysteine. Cysteine. What happens with ganticurium is it is metabolized one by ester pathway. The other one is ganticurium combines with cysteine in the body, forms something called cysteine adjunct product. Cysteine gets addition to ganticurium structure. Okay, that's how it's excreted. So therefore, the best reversal agent for ganticurium is going to be L-cysteine. L-cysteine. Cysteine is a reversal agent for antidote for cysteine. N-acetyl cysteine is antidote for. Exactly, you answered that. All right. Okay. So this is the story of reversal agents: 2-aminopyridine, the story of physiostichmine, neostichmine, pyridostichmine, sugammadex, and L-cysteine. Got you? Right? What are the clinical signs of adequate reversal? When do you say that the patient is completely reversed and you can shift the patient from the OT to the ward? See, what happens is when you anesthetize the patient, you give relaxant to the patient, all the muscles of the body are paralyzed, skeletal muscles are paralyzed, and before you shift the patient to the ward, you need to make sure that the patient is completely recovered from relaxation. What happens if you shift, if you do not determine, if you are not sure about whether the patient is completely reversed or not, what's going to happen is the patient may go into paralysis after shifting to the ward and the patient may die of hypoxia. So before I shift the patient to the ward, I want to make sure perfectly that the patient is completely reversed. Right? So how do you know that? What are the clinical signs? First thing is, if you have peripheral nerve stimulator, train of 4 greater than 0.9 ratio. Train of 4 ratio greater than 0.9. Okay? I'm not going to discuss about the peripheral nerve stimulation. Okay? It takes a lot of time. But I've discussed in my sessions. Train of 4 ratio, there's something called train of 4 ratio. If the train of 4 ratio is greater than 0.9, I can be pretty sure that the patient is completely reversed. I can send the patient to the ward. That is only if you have peripheral nerve stimulator. Let us say you are practicing in a nursing home and you don't have a peripheral nerve stimulator. So what do? Very good. Sustain head lift. Sustain head lift. You ask the patient to lift their head and keep it elevated for greater than 5 seconds. Sustain head lift greater than 5 seconds is a clinical sign of adequate reversal. Or tongue blade. If the patient can hold the tongue blade tightly between the incisors or canines, then it's a sign of adequate reversal. These are the two signs of adequate recovery. Okay? Adequate recovery does not mean if he is able to move the limbs. That is not adequate recovery. Adequate recovery is only sustained head lift and sustainability of the tongue blade. Okay? So neostichmine. Shortest acting non-depolarizing muscle relaxant is, if you have ganticurium, choose ganticurium. If you do not have ganticurium, you choose mivacurium. Okay? All are true about curare poisoning except orally non-toxic. Is D-tuberculin orally bioavailable? What did I tell you about non-depolarizing muscle relaxants? They are not absorbed orally. They do not cross blood-brain barriers, so they cannot be absorbed. So even if you drink pancuronium, vecuronium, you're not going to die. Okay? We had a patient with pancuronium ingestion. She ingested pancuronium vial, and people were all surprised whether she was going to paralysis or not. Okay? They're not absorbed orally. It's okay to drink pancuronium if you want to drink. It's tasty too. All right. So orally, it's non-toxic. Okay? Curare, does it cause flaccid paralysis or spastic paralysis? Almost all non-depolarizing muscle relaxants cause flaccid paralysis. Is it treated with physiostichmine? It can be treated with physiostichmine, but the drug of choice is neostichmine. Causes non-competitive inhibition of acetylcholine receptors. Is it non-competitive or competitive? Competitive blockade. Okay. Which of the following non-depolarizing muscle relaxant is excreted maximally through the kidney? Galamine. 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 Maximally galamine. To counter central anticholinergic effect, drug used is, wow, physiostichmine. Okay? Physiostichmine. Which of the following anesthetic agents is contraindicated in renal failure? Galamine. It's the same concept being asked so many times. Okay? The commonest cranial nerve involved in toxic manifestation of trichloroacetylene degradation product is You have the answer there. Alright, so the problems with soda lime. What are the problems with soda lime? We'll discuss that, okay? Problems with soda lime. Trichloroacetylene reacts with soda lime, generate two degradation products. One is phosgene, the second is 2-chloroacetylene. Trichloroacetylene reacts with soda lime to generate two products. One is phosgene, the second is 2-chloroacetylene. Phosgene causes what? Phosgene poisoning causes what? ARDS. It causes ARDS. 2-chloroacetylene is neurotoxic. 2-chloroacetylene is neurotoxic. Neurotoxic in the sense it can cause encephalopathy or cranial nerve involvement. The most common cranial nerves that are involved are 3rd, 5th and 6th cranial nerves. Okay? So trichloroacetylene reacts with soda lime to generate phosgene and 2-chloroacetylene. Phosgene causes ARDS. 2-chloroacetylene is neurotoxic. Neurotoxic in the sense it can cause encephalopathy or cranial nerve involvement. 3rd, 5th and 6th cranial nerves are the ones which are most common. Okay? Usually all facial, eye and facial cranial nerves are the ones which are usually involved. Okay? Alright? So which cranial nerve is affected? First and second are very rare. 5th can be affected. Trigeminal nerve can be affected. If 3rd is given, choose 3rd. If that is not given, choose 5th. Okay? Right? What are the other problems with soda lime? Desflurane reacts with soda lime or berry lime to generate what? Desflurane reacts with soda lime. Did you guys read? Have read Anaesthesia? For the first time you're hearing me. Alright. Desflurane reacts with soda lime or berry lime to generate carbon monoxide. Okay, desflurane reacts with soda lime or berry lime to generate carbon monoxide. Sevoflurane, very good, especially at less than 2 liters per minute. When it is desiccated, it releases something called as compound A. Compound A is toxic to nephrotoxic. Very good, nephrotoxic. Okay, these are the problems with soda lime. Alright. So what is the newest carbon dioxide absorbent? Amzob. Amzob does not have any of these problems. Okay. With soda lime you have all these problems. Amzob does not have any of these problems. Alright. And one special mention from forensic, chlorocresol causes facial palsy. Chlorocresol causes something like Bell's palsy. Okay, just remember. Trichloroacetylene causes trigeminal or 3rd cranial nerve palsy. Chlorocresol is a compound that can cause specially facial palsy. Okay, that's reversible too. Just remember for forensic sake. Okay. Maximum duration of action is seen with pancuronium. What is the duration? 1 hour.